Hello, everyone. My name is Poorvi. I'm the medical ICU specialist here at Christ in the MICU. And today my topic is looking at some flaws in alcohol withdrawal management. So I just want to start off by saying this is a very exciting topic. I'm sure you guys all have a lot of fun managing these patients at the bedside. They do take up a lot of our time and energy and resources. And I think what's kind of exciting though about this disease state is that we don't have any standardized guidelines. There's only a handful of medications, yet there's so many different ways and approaches to treating this disorder. And then what makes it challenging is that we don't have any guidelines. There's only a handful of medications, and everybody has a different way of approaching it. So today I'm going to kind of talk about what some common flaws are, though, in the diagnosis and management of alcohol withdrawal. And really what I want to bring home is that we've been very stagnant in how we've been managing this disease state for decades and decades, and it really is time for a different approach. There we go. I have no conflicts of interest to disclose. And really, I'm going to identify three major flaws to go over today and some strategies to help overcome those flaws. So the first flaw I'm going to talk about is the diagnosis. And I'm sure this has all happened to us, or maybe we've been part of the debate. Hey, this patient is intoxicated. No, this patient is withdrawing. And there's this constant battle back and forth between are they intoxicated or are they actively withdrawing? So I've seen that debate even amongst my intensivists that I work with, and it does become a little bit challenging. So when we look at the diagnosis of alcohol withdrawal and intoxication, the ICD-11 codes kind of show us that, intoxication typically occurs during or shortly after the consumption of alcohol, and typically we get a very slowed CNS kind of, manifestation. However, then we have this aggressive behavior that can occur, and I'm sure we've all seen, or maybe you've been one of those people in the past, the angry, violent, drunk person, at a party or wherever. But that aggressive behavior then tends to, get a little confusing because when you look at withdrawal, the presentation is that type of agitated, and hyperactive patient. Well, what I want to point out is that, withdrawal occurs with cessation, but it also occurs with reduction in the use of alcohol. So just because you are still drinking doesn't mean that you can't go into withdrawal if you normally drink a lot more than what you're drinking now. And I think sometimes that confuses the picture because then we get this blood alcohol level that's 300. And then that throws us for a loop because we're like, oh, the blood alcohol level is 300, this patient must be intoxicated. However, we all know that the diagnosis of alcohol withdrawal should not be based on a blood alcohol level, as that serum level can be elevated, it can be high, and that patient can still be withdrawing. So we have patients at our institution that live at 700 or 800. So when they hit 300, they are actively withdrawing. So sometimes we get a little tripped up by that blood alcohol level, and then it delays us in aggressively managing that patient. So the next flaw that I'm going to talk about is prophylaxis, and I'm going to really focus on the lack of prophylaxis really being the flaw. And it's funny because as critical care clinicians, we are so ingrained with prophylaxis, VTE prophylaxis, stress ulcer prophylaxis, antibiotic prophylaxis for surgical procedures, antiemetic prophylaxis for chemotherapeutic drugs. But when it comes to alcohol withdrawal, we don't really think about prophylaxis in those patients. And there are certain high-risk patients that we need to be watchful for, that we need to be on top of kind of identifying the second they come through our door, because that CWA score of 0 is not going to last very long, and I see my nurses nodding because they're the ones who manage these patients at the bedside. And that's so true. If you have a high-risk patient who drinks a heavy amount of alcohol, somebody who has a history of alcohol withdrawal, seizures, or delirium, or starts to withdraw within 2 to 4 hours after cessation of alcohol, you have a high-risk person that probably warrants prophylaxis. So it's a really good idea to start risk stratifying those patients, identifying those patients early, and then potentially start something for prophylaxis. So what would we start? We obviously have our benzodiazepines. However, we are trying to move away from using and overusing benzodiazepines. As we know, their abuse potential is there. It potentially increases alcohol consumption and cravings. It leads to delirium, and most of these patients, the organ that tends to be impaired is the liver. So there's more accumulation and hepatic failure, and then you just have more prolonged and oversedation that comes with it. But with a drug like gabapentin, we have a different agent that works to help increase GABA synthesis by an indirect mechanism. It actually decreases cravings and alcohol consumption, and it actually avoids the liver, metabolism altogether. So typically, our patients with alcohol withdrawal are not coming in with renal failure. So there's less potential for accumulation since it's bypassing the liver and it's renally excreted and can be renally adjusted if need be. So I was going to move on. There we go. To the last flaw, and this is where I'm going to spend most of the time talking on the acute management of alcohol withdrawal. And the flaw really is in the lack of use of adjunctive agents or the delayed use in adjunctive agents to treat alcohol withdrawal. So this is a common scenario that we face, finding the right sedation balance where the patient, if you give them, not enough drug, they escalate in their symptoms, they end up intubated. You give them too much drug, you've oversedated them, they can't protect their airway, you end up intubating them. So each patient has this fine balance in this window of where we can kind of find the right combination of doses and drugs to manage that patient without over or underdoing it. And that is very difficult, and it's different for every patient as their tolerance levels are variable. So for mild to moderate alcohol withdrawal, we typically define that with the CWA score of less than 15, and we typically give them symptom-triggered therapy. So I'm sure, and maybe I'll ask some of the providers in the room, how many people still use fixed dosing of benzodiazepines to manage acute alcohol withdrawal? Anyone? No? Because I still see it in practice where you schedule that Librium, that Valium, that long-acting benzodiazepine. And the fixed dosing strategy in acute alcohol withdrawal management actually leads to a prolonged withdrawal period, and it actually increases exposure to benzodiazepines. Where symptom-triggered therapy is where you have that CWA protocol, and you give the PRN medication based on the CWA scores, and the doses are often escalated as the CWA score escalates, and that really is the preferred dosing regimen. However, what about adjunctive agents? Because then I'll see the combination of that Librium scheduled plus the PRN Ativan that we're going to give them. But why scheduled long-acting benzos? Why not something else to combine with the benzos? So adjunctive medications is not a foreign concept to us. As combination therapy and adjunctive medications we do in critical care medicine all the time. We have started to move away from maximizing a dose of norepinephrine for shock and then adding vasopressin plus or minus angiotensin II. We're now trying to hit those patients with combination of pressors earlier on. We do that with so many other disease states. In hypertension, we don't hit them with 400 milligrams of metoprolol and then think about a second antihypertensive agent. HIV, oncology, all disease states that we use a combination of a multitude of drugs. But why not for alcohol withdrawal? Why do we just kind of continue to go down the realm of giving them benzos and more benzos and more benzos? So what I'm going to focus on today is one particular adjunctive medication that can be utilized in mild to moderate alcohol withdrawal. And I'm having trouble with my clicker. So as far as the benefits of adjunctive medications, they reduce benzodiazepine requirements and therefore minimize their adverse effects from drug accumulation. We have synergistic control of symptoms, and then we have potential long-term benefits of reduced alcohol consumption and cravings depending on the agent that you use. And for all my nursing colleagues in the room, think about the number of times that you go into that room to do a CWA score, to push a medication, to go back and evaluate if that medication has worked. You are in there constantly, making that patient almost a one-to-one when you have other patients to care for. So by providing adjunctive medications, it allows that patient to be controlled for a longer period of time without having to kind of constantly give a push dose of something, which definitely minimizes our nursing resources and time. So the agent I'm going to focus on today is, all right, there we go, gabapentin. So gabapentin, although it's a very old drug, for alcohol withdrawal, it still seems to be evolving. I have a lot of differences in opinion, even amongst the intensivists that I work with on this drug. Some love it, some do not love it. So what I wanted to kind of point out, and I know this is a very busy slide, is that from 2003 to 2013, there were only a handful of studies. But then all of a sudden, last year to this year, 4 more studies came out. And basically what gabapentin is showing us consistently in all of this data is that there's less benzodiazepine usage, there's an improvement in their CWA scores and symptom control, and now we're already starting to see with some of the later studies impacts on length of stay, and some of the resources that we use. So gabapentin in mild to moderate withdrawal is actually a pretty good adjunctive agent that you could start thinking about early on in your mild to moderate floor patient, even before the patient, starts to become severe, because the whole purpose is to try to minimize the amount of PRN benzos we need while still effectively treating them with something that works with the mechanism of action that we need for alcohol withdrawal. Sorry, clicker. Okay, then we'll move on to severe alcohol withdrawal, our favorite type of patient with that CWA score of 25. So CWA scores greater than 15 define usually severe alcohol withdrawal. And then benzodiazepine resistance is something that we are facing every day now. More and more patients are coming in not responding to our typical doses of benzodiazepines. So then what do? We, start to throw them in the ICU and then start them on a continuous sedative infusion, right? And the definition of benzodiazepine resistance is 40 milligrams of diazepam or equivalent benzo in the first hour or 200 milligrams in 3 hours. So for those of you that use lorazepam, that's only 8 milligrams of lorazepam in an hour. Think about how many times you hit that threshold. I know, you guys are laughing because you know like how fast that happens. So exactly, we hit that threshold so quickly. And what do? We give them more benzos, and then we throw them in the ICU and they start some type of drip. So no matter what sedative infusion you pick, and I'm not here to debate whether it's lorazepam, ketamine, propofol, or Precedex, whatever drip you pick, when you start a continuous sedative infusion, the intubation rates go up and your ICU length of stay is prolonged. So if you can find a strategy or an agent to basically avoid the need for a continuous sedative infusion, you actually will help benefit the patient by reducing these two complications or prolonging their length of stay. So anyone think of a drug that might do that? I know our hospital uses it a lot. So what might be an agent with a long-acting duration that can help avoid needing a sedative infusion? So I'm sure you guys are thinking phenobarbital. Yeah, with phenobarbital, it's a barbiturate. It works synergistically with benzodiazepine. It has a 96-hour half-life once you've fully loaded somebody and hangs around for a while. So that's, got a lot of benefits. But then we have this fear of phenobarbital, right? There's this culture and this fear that, oh my gosh, phenobarbital, that's going to induce respiratory failure, and then we're going to intubate this patient, and that's the end all be all of everything. So I still struggle with this. In certain areas of the hospital, I get phone calls from the floors, the ED, and different places in which phenobarbital is still kind of emerging. In the ICUs here at Christ, we've been using it for a long time, so we're comfortable with it. But it really is just a culture change, and it's something that we need to kind of start to explore. So when we look at the data for phenobarbital, sorry about the busy slide again, but what I wanted to point out is there's a plethora of studies that have come out recently, and there's more on another slide, and basically that fear of respiratory depression is not being seen in our literature. So what our literature is showing us that you either do not increase the intubation rate, or you have no difference in complications, or you actually reduce mechanical ventilation rates with phenobarbital. And why is it that we see that in this patient population? It's because these are not naive patients. They have a huge sedation tolerance level because of their alcoholism. So it would be like giving 4 milligrams of morphine to an opiate naive patient versus an opiate tolerant patient. Yeah, you might overdo it with a naive patient, but you probably aren't going to cause respiratory compromise in an opiate tolerant patient at that dose. The same thing holds true with phenobarbital. They tend to tolerate these doses of phenobarbital a lot more than your average patient would. And then the next slide has really a lot more recent literature, just 4 more studies between last year and this year with phenobarbital. And really want to point out that most of these are ED and ICU studies. However, we now have, in 2019 this year, a study looking at phenobarbital in general medical floor patients. So we're now expanding out of the ICU onto the floors using a drug that at one time was so scary and using it in other less monitored areas of the hospital. And what they basically did is they risk stratified these patients by respiratory compromise risk. And if they had a higher risk of respiratory compromise, they got a lower dose of maybe 6 to 8 milligrams per kilogram of phenobarbital. If they had no complications or risk, they got a higher dose of 12 to 15 milligrams per kilogram. And basically, they found no difference in outcomes or complication rates. So that's what I kind of wanted to point out. And then the other debate about phenobarbital is how do you dose it? You know, do you give them low intermittent IV push doses, or do you give them high front-loading doses? And of course, that high front-loading dose tends to scare people because of the respiratory depression associated with phenobarbital. So if we go back here to the Rosenson study in 2013, there was an ER study. They gave a front-loading dose of 10 mg per kg and did not find any difference in their intubation rate. And most of the other low intermittent studies also found either no difference or reduction in mechanical ventilation. So to date, we don't really have any comparative data looking at one dose versus the other. So I will share with you our own internal data. We just did a before and after analysis looking at low intermittent dosing of phenobarbital versus higher front-loading doses of phenobarbital. We just presented this data at American Thoracic Society earlier this year, and basically what we found was a drastic reduction in our mechanical ventilation rates from 63% to 28% with the use of high dose of phenobarbital. Our frequency of sedative infusions fell from 95 to 71%. Length of stay did not reach significant statistical significance, but a 41-hour length of stay reduction, I think clinically, to some of us might be considered significant, and then respiratory depression rates were not increased. So really, I guess what I'm trying to point out here is this front-loading dose strategy that sometimes gets a bad rap. In data that we've seen in the literature and our own internal data, we're not finding it. If anything, we're finding a benefit with that. So the front-loading dosing strategy of phenobarb can actually reduce mechanical ventilation rates and sedative infusion rates and potentially impact your length of stay. I just looked at some 2018 data for our unit, and basically the numbers were very similar. Mechanical ventilation rates were about 28%. However, our frequency of sedative infusion rate, I haven't even shared this with our ICU medical director yet. So our frequency of sedative infusion rates down to 46%. Less than half of these patients are getting a continuous sedative infusion when they are some of the most severe alcohol withdrawal that I've seen in the 5 institutions that I've worked at or trained at. Our ICU length of stay was 111 hours in 2018, and our respiratory depression rates were about the same. It was like 3.6%. So, and what I wanted to kind of look at is, well, what's the difference? Why did we use less infusions? And it had to do with the fact that instead of giving one dose of 10 mg per kg, 64% of these patients got 2 doses of 10 mg per kg. We were giving 20 milligrams per kilogram of phenobarbital without increasing their respiratory compromise or increasing mechanical ventilation rates. So phenobarbital, with that long-acting duration of action, has the potential to negate the need for an infusion, making it a much easier patient to manage, potentially even being able to transfer that patient out sooner, because we know as long as they stay on a drip, they're likely to probably stay with us longer. So to kind of summarize my flaws, don't base your diagnosis on a serum alcohol level, as a patient can actually be withdrawing with even high levels of alcohol. Do provide prophylaxis and start risk stratifying those patients early on to see if they could benefit from some prophylaxis. And then do provide adjunctive agents and start to think of this disease the way we do with other disease states, where it really is about combination therapy. So my philosophy on alcohol withdrawal, as my intensivists know, is go big or go home. Okay, this is not a disease state to mess around with, to wait, let it escalate. Those patients end up getting intubated, staying in the ICU a lot longer. So if you're going to take, a risk, take a risk in adequately treating that patient aggressively and early on. So I'm going to leave you with just a quick treatment algorithm. I will red flag caution you. This is a little bit of data, a lot of bit of personal experience and opinions. All right. So for prophylaxis, like I said, high-risk patients probably do need prophylaxis. My preference is to use gabapentin over benzodiazepines for the advantages that I mentioned. For a mild to moderate alcohol withdrawal patient, There we go. With CWA scores of less than 15, we can do symptom-triggered therapy with benzodiazepines, but combining that with some gabapentin might really decrease the amount of nursing resources and push dose benzodiazepines we end up giving them. Why I say gabapentin in mild to moderate versus severe, the data with severe is very conflicting with gabapentin, and it's also much harder to get a patient in severe withdrawal to take an oral pill. I would think the nurses would probably agree with that. And so for severe withdrawal with CWA scores of greater than 15, lorazepam, don't wait to give 20 to 40 milligrams lorazepam. If you've given that much lorazepam, sure, when you give the phenobarbital, you will intubate your patient. But guess what? We like to blame the phenobarbital, but it's not pheno's fault. It's the 20 to 40 milligrams of Ativan that you gave. It's that drug's fault. So phenobarb gets a bad rap for that, but you have to look at how much you've given of benzodiazepines before you give them their phenobarbital. So really don't mess around. After 8 to 12 milligrams, you've met benzodiazepine resistance criteria. Load them, give them their phenobarbital. For us at our institution, if one dose doesn't work, we'll go with the second dose before we commit them to a drip. I've even started using maintenance doses where I schedule them, almost like treating them like a seizure patient. You load them, and then you give them a maintenance dose. We'll do double loading, and then we'll put them on maybe something like 130 milligrams Q8 hours scheduled to kind of keep those levels therapeutic. And that really, for a lot of our patients, has negated the need for a sedative infusion. And with that, these are my references, and here's some contact information if anybody has further questions. Do want to give 3 quick shout outs. One, to the MICU nurses, because they are dealing with an extremely difficult patient population. I've worked in 5 institutions, including a VA hospital. I have never seen alcohol withdrawal the way I've seen it at Christ Medical Center in the MICU. So woo, go Christ. So yeah, number 2, I want to just give a shout out to the internal medicine and the emergency medicine residents. They have done a phenomenal job of taking what they've learned in the unit and applying that out on the floors and in the ICUs, making those patients we receive from them much easier to treat. And the last shout out goes to my intensivist, because I literally have come up with some crazy drug dosing combinations that they have been so supportive of, and they haven't thrown me under the bus, and they've been open to trying things out. And for that, without them, I would not have been able to come this far. And over the past decade of me being here, we would not have been able to produce the outcomes that we've produced. So thank you all very much.